All right, welcome. Thanks for coming today and for joining in on this presentation on managing blood pressure. A simple topic, yet so profound. I guess before we get started, I think it might be good for me to introduce myself because this is my first uh, session that I'm doing with you guys. I'm a new faculty member. My name is Konrad. I'm a new faculty member here at Sac State. And I have been a physical therapist for the past, let's say 20 plus years, 21 years. I studied in Massachusetts at the University of Massachusetts, got my bachelor's in exercise physiology, did my master's in physical therapy, and then I started my professional career working in the hospital setting at Mass General Hospital in Boston and at the Leahy Clinic in Burlington, Massachusetts. Beautiful town. That is, both Mass General is huge. You're lost. And I was there right during 9/11, and it was just crazy.
Oh, wow.
So it was something that I will never forget. So yeah, so started at Mass General and then went on to do my clinical doctorate in physical therapy, which was not an entry-level degree at that time. And then once I finished my clinical doctorate, I applied for a full-time faculty position, and I took up a faculty position at a private university in St. Louis, Missouri. The name of the university is Maryville University in St. Louis, small private school, and I taught there for 18 years. And I transitioned now to Sac State after 18 years at the same place. So while I was at Sacramento, while I was in Missouri, I went back to school and I got my PhD in physical therapy. You know, whenever you see all these letters behind some people's names, you shouldn't think how much knowledge he has. You should be thinking, how much money has he really spent? That's really the question. How much money has he spent more than how much knowledge he has in that brain, right? A lot, but I think it has come to good use. And my area of specialty is really in cardiovascular and pulmonary physical therapy. Very, very few of us in the country with the cardiovascular and pulmonary specialty in physical therapy, probably less than 1,000 of us in the country with this specialty area. And so I'm really passionate about this area. I teach this content area in the curriculum. I have worked with patients. My area of research and expertise is really in heart failure. So I do most of my stuff in the area of heart failure. And I'm looking forward to working with you guys. I've built a good relationship with Linda. We have some projects going on. We're actually looking at starting a research study, collecting some data on patients with in the cardiovascular wellness program. We're currently going through approval with the IRB, so I don't want to say too much about that, but we're hoping we can initiate that research study that will be open to you guys once we get approved, which is hopefully going to be in the next month. I'm actually just working on the approval on another screen right now. So that's as we speak. Again, I would love to do more of these, so I'm really open to your feedback, to your, if you want me to talk about something related to exercise, related to therapy, related to cardiac rehab, please feel free to let me know, and I'll be happy to kind of, talk about that in future sessions as we go on. All right. So today's talk is really about blood pressure management. And okay. We kind of want to go into both ends of the spectrum, starting with high blood pressure, kind of defining hypertension, talking about the classification of hypertension based on new guidelines. We'll talk about lifestyle evidence-based interventions. And we may not get through all of this today. Whatever we can get through is what we get through. And if we don't, we'll kind of continue it in another session. So I'm not in any, it's not like a class where I have to get through a certain amount of content in 50 minutes. I'm open to your questions. We can just have a casual conversation on this information. And then we'll get into hypotension, low blood pressure, and kind of what that means as well. And then we'll kind of conclude things for this presentation. All right, so, for decades, for years, I think even before maybe when I was a little kid, we always defined high blood pressure as a blood pressure greater than 140 over 90, right? When you think about people having high blood pressure, you usually think about people having a blood pressure greater than 140 over 90. And that was always the case until November 13th, 2017, when the American Heart Association and American College of Cardiology changed the guidelines. They changed the guidelines. And they basically say now that if your blood pressure is greater than 130 over 80, you are considered hypertensive, right? 130 over 80. So those are the new guidelines based on a very important paper that was published by Welton and colleagues, published by the American Heart Association on November 13th, 2017. A third of all Americans have hypertension. 2/3 of individuals greater than 60 have hypertension. And it's really important to appreciate that hypertension, high blood pressure, is the most prevalent modifiable risk factor. It's modifiable. So if we can get people to control their blood pressure, we can really reduce the amount of cardiovascular events. We can really significantly reduce the amount of mortality and death because of cardiovascular disease in society. So out of all the modifiable, out of all the risk factors, the most prevalent modifiable risk factor is hypertension. So with that preface, let's talk about what are the new guidelines. So when we look at the new guidelines, normal blood pressure today is defined as a blood pressure less than 120 over 80, less than 120. So pretty much we're all hypertensive, right? We're all pretty much, how many of us have blood pressures less than 120 over 80? But based on the paper published on November 13th, if your blood pressure is less than 120 over 80, you are said to have normal blood pressure. And if your blood pressure is normal, that means what we recommend for people is healthy lifestyle choices, which I'm going to talk about, and annual physicals to get your blood pressure checked at least once a year. If your blood pressure is 120 to 129 systolic and under 80 diastolic, we now say you have elevated blood pressure. Elevated blood pressure. If your blood pressure, your systolic blood pressure is the range of 120 to 129, and your diastolic blood pressure is under 80, elevated blood pressure. And even if it's elevated, no big deal. It's not a real problem. We say you continue to kind of incorporate lifestyle changes, diet, exercise, alcohol consumption needs to be reduced. We'll talk about those lifestyle changes in a few slides down. Get your blood pressure checked 3 to 6 months. So incorporating some lifestyle choices if you're not doing so already. If your blood pressure is 130 to 139 systolic or 80 to 89 diastolic, that word or is important. So it's not 130 to 139 and 80 to 89. It's 130 to 139 systolic or 80 to 89 diastolic. We now say you have stage 1 hypertension. Stage 1 hypertension. Now, if you have stage 1 hypertension, the next thing, so let's say you go to the doctor's office and they take your blood pressure and they measure a certain value. The next thing that they should be doing, the next thing that the American Heart Association is advocating physicians to do, is to look at your 10-year risk for having a heart attack or stroke. What is your 10-year risk for having a heart attack or stroke? Okay, so how do they calculate that 10-year risk? They look at your age, they look at your cholesterol levels, they look at your glucose levels, they look to see if you're a smoker or you're a non-smoker. They look at all these variables, and based on all these variables and their levels, your level of cholesterol, your level of HDL, your level of triglycerides, they give you some numbers. And they add up all the numbers, they give you a score. And based on that score, it determines your risk for having a heart attack or stroke in the next 10 years. And based on that risk, if that risk is less than 10%, if that risk is less than 10%, even though your blood pressure is 130 to 139 or 80 to 89, we just recommend lifestyle changes. But if your risk is greater than 10%, now they recommend one antihypertensive medication. One antihypertensive medication. If your blood pressures are in that range and your risk for having a heart attack or stroke is greater than 10%. How do you calculate the risk? I gave you the QR code. You can just take your smartphone and you can shine your smartphone on that QR code and you can calculate your own risk. Right? So if you look at it, it asks you your age, it asks you your gender, it asks you your race, it asks you your cholesterol level. You put all those numbers in, and you can calculate your risk for having a heart attack or stroke in the next 10 years. So if you are a UC Davis patient and you have my chart, you can pull up your lab values. I can pull up mine, right? You can pull it up. You can put those numbers in and you can get your risk. How cool is that? All right, good. Okay, so I want to go back to the previous slide. Oh, all right. So if your blood pressure is 130 to 139 or 80 to 89, and your risk, you're said to be in stage 1 hypertension. Now, if your blood pressure is greater than 140 90, is that a question? Okay. If your risk is greater than 140 over 90, now we say you're in stage 2 hypertension. And if you're in stage 2 hypertension, then we recommend 2 antihypertensive medications along with monthly follow-up changes. So we kind of recommend you to get your blood pressure checked every month so that we're giving you the correct dosage of medications. We're not giving you too much. We're not giving you too little. We want to keep your blood pressure around the 130 range. We don't want to keep your blood pressure, too much higher than 130. So we kind of titrate the medications with monthly follow-ups to make sure that's in the range. Questions so far? Paul?
Is it possible to get it lower and then either eliminate or decrease your medication?
Yeah,
dosage?
absolutely. So what the hope is with prolonged, so the question was, can it be possible to titrate or decrease the medication dose? And that's really the goal, to try to get people to be more involved in lifestyle management, because if we take care of people's lifestyle, then that exercise and that diet and that salt reduction can get people to actually get off these medications. I mean, you know better than me that these medications have their own issues. So getting off some of these medications because of your participation in exercise and diet and lifestyle can be really beneficial. And I just published a paper, and Dr. Lopez actually reviewed that paper on the importance of lifestyle changes in patients with atrial fibrillation. And there's a new body of evidence, brand new evidence, talking about how you can completely reverse atrial fibrillation just with lifestyle. Most physicians think you need medications, and once you have atrial fib, you live with AFib for the rest of your life. But now there's new data that just lifestyle, and I'm going to do a whole session on that, can be meaningful in reversing atrial fibrillation. So that's coming up in another session. All right. Other questions so far? We're coming to that. Low blood, we'll talk about low blood. That, especially when you're taking all these medications, right? You can get something called orthostatic hypotension and low blood pressure. And how do we define that? Is a really good question. We're coming to that in a few slides down. Maybe not today, but we'll follow that up maybe after spring break, because next week is spring break. You're in the university now, so we get spring break. So anyways, so the question that begs consideration, right? The question that begs consideration is, for decades, as I mentioned, we always defined hypertension as a blood pressure greater than 140 over 90, right? That's how we always considered hypertension. Blood pressure is greater than 140 over 90. Why did the American Heart Association change the guidelines? Was it because some pharmaceutical company just wants to make more money? Why did the American Heart Association change the guidelines? And the American Heart Association changed the guidelines because of a really important study, a landmark study that was published in the New England Journal of Medicine called the SPRINT trial. The SPRINT trial. And this was the study that changed the guidelines. And all we're going to do today is talk about, what does the SPRINT trial mean to you as a patient? That's all I'm going to talk about today. What does it mean to you as a patient? Right? So SPRINT stands for Systolic Pressure Intervention Trial. That's what SPRINT trial stands for. Systolic, PR, pressure, INT, intervention trial. And the SPRINT trial asked a really simple question. They asked a really simple question. The researchers in the SPRINT trial, they said, for decades, we always gave people medications if their blood pressure was greater than 140. If their systolic blood pressure was greater than 140, then we gave people medications to keep their systolic blood pressure under 140. That's what we always did. But what if we give people more medications to keep their systolic blood pressure under 120? If we give people more medications to keep their systolic blood pressure under 120 instead of under 140, will there be added benefit? Isn't that an interesting question? You with me? So we give people medications to keep their blood pressure under 140. Let's give them more medications. If we keep people's blood pressure under 120, will it help? So they did a multi-centered randomized controlled trial, which is the highest level of research, where they took centers all over the United States. And they recruited over 9,000 patients from all over the US. I don't know, were any of you in the study? You don't have to tell me, but it would be cool if any of you were in the study. They did studies in California, all 50 states. Okay. So what were the criteria? You went to the doctor's office for a physical. When you went to the doctor's office for a physical, if you were greater than 50 years of age, if you had never had a stroke, if you did not have diabetes, did not have a stroke, you were more than 50 years of age, and your risk for having a cardiovascular event based on the risk estimator was greater than 10%, the doctor at the physical said, you know what, we're doing the study. And we don't know if more medications are better or less medications are better. Your blood pressure is higher than 130. You've never had a stroke. You don't have diabetes. You're over 50 years of age. Your risk for having a heart attack or stroke is greater than 10%. Do you want to be part of the study? If you said yes, you signed the informed consent, you signed your life away, and then they randomized you into two groups. One group, they gave them more medications to keep their systolic blood pressures under 120. The other group, they gave them less medications, kept their systolic blood pressures under 140, in the 135 to 139 range. How did they measure the people's blood pressure? All right. So you went to the doctor's office. They put an automatic cuff on your arm. And that automatic cuff was a very expensive automatic cuff that cost $800. Okay, it was not the one from Walmart. Okay, it was a really expensive automatic cuff. And they put it on, and they kept you in this room for 10 minutes. No coffee, no smoking. You sat quietly in the room for 10 minutes, seated, and then no one was in the room. Nobody was in the room. And the automatic cuff took one reading. It waited a minute. It took a second reading. It waited a minute. It took a third reading. And the average of the three readings is what they used as the systolic blood pressure to treat. So that's how they measured blood pressure. Once they got your blood pressure, they sent you home on a certain amount of medications, and they called you in every month, 1 month, 1 month, 1 month. Every month you got your blood pressure checked to titrate the dose to make sure it was in that 135 to 139 range, or that under 120 range, depending on where they wanted to be. And you went once a month for every 3 months, and then every 3 months thereafter. They were planning to follow these patients for 5 years. From the initiation of the study, they were planning to follow these patients for 5 years. But when you're doing such a big study in the United States that is funded by the NIH, you have to give your data to the NIH periodically. You have to do this, something called the data monitoring system. They monitor the data just to make sure that there's no adverse events. And so the data monitoring services in Washington, D.C., through the NIH, they stopped the study early. They stopped the trial early. They stopped the trial early because of superiority of the intensive therapy compared to standard of care. So they were like, oh my gosh, people who were getting more intense blood pressure management, they had such better results compared to people who are getting less intense. It's not ethical. So we're going to stop the study early. So what were they measuring? They looked at two major things. They looked at a composite variable that looked at the number of events. How many patients had cardiovascular events? And that event could be a heart attack, the myocardial infarction. It could be chest pain, we call acute coronary syndrome. It could be developing heart failure. It could be developing a stroke, a CVA, which is a cerebrovascular accident, a stroke, or death, just the number of events. So they looked at how many people in the more aggressive group had an events as composite, versus people in the less aggressive. And the second major thing they looked at is all-cause mortality. How many people were dying? So they found 25% fewer events in those that were more aggressively treated compared to those that were less aggressively treated with medicine. So if you look at the total sample is 9,300 people. 9,300 people were in the study. 4,500 were given more medications. 4,500 were given less medications. You agreed? Half and half. So out of the 4,500 or 4,600 people that were given, 5.2% had an event. Out of the other 4,500 people, 6.8% of those 5,400 people had an event. And there was a significant difference in the number of events between the two groups. Only 5% of those 4,500 people in the more aggressive group had an event. Only 6.8% of people in the less aggressive group had an event, and there was a significant difference between the number. So basically what they found is that giving people more medications significantly reduced the number of events, cardiovascular events, within 3-year follow-up. The second thing they found was they found a 27% reduction in all-cause mortality. 3.3% of the 4,500 people in the more aggressive group died. 4.5% of the 4,500 people in the less aggressive group died. So they said, and there was a significant difference. So they determined that giving people more blood pressure medications reduced death. Just giving people more medications reduced their death. And because they found such great results, they changed the guidelines. Yes, medications, the intensive therapy arm that received more medications had more syncope, they were lightheaded. They had some electrolyte abnormalities, their potassium levels were messed up, and they caused some kidney injury, acute kidney injury. But these negative effects far were less than the benefits. The benefits far outweighed these negative risks. And because there was so much more benefit, they changed the guidelines. So as you listen to me about this study, does anything come to your mind? What do you like about the study? What do you not like about the study? Let's have a conversation as a patient.
What did they say about lifestyle issues?
So everyone got lifestyle education, whether you were in the more aggressive group or less aggressive group. They didn't control for that, but everyone was given the same education on lifestyle.
But did they present the differences that the more aggressive people stopped smoking more or ate better? Or
They didn't control for that. So they did not look
measure.
Because it was such a large sample. So they just gave everybody the same education, and they only manipulated the medications. They didn't manipulate the lifestyle. So what do you think came to my mind, or what comes to when I was reading the study in my office? This is what I sit and do in my office. I read all this nonsense. What comes to my mind? What do you think came to what comes to my mind as you think about the study? Okay, probably they're going to push more medications, right?
Drug companies benefit the most.
Okay, you're probably thinking drug. So the first question that came to my mind is, should somebody who is 85 years old really have a systolic blood pressure under 120? I mean, do you really want somebody who's 85 years old to have a systolic blood pressure under 120? That's the first question that came to my mind. Does that question come to your mind? It definitely came to my mind. So as I think about the study, right, when you look at the sprint population, when you look at the people in the sprint study, 27% of the sprint population, 27% of the sprint population, 27% of the 9,300 people were greater than 65 years of age. Greater than 65. Okay? Yeah, no. So the recruitment was over 50. Oh. But if you looked at number of people over 65, it was 27% of the population. Right? Yeah, go ahead. Yeah, so they didn't look at 85. They just looked at 65 as a cutoff, right? So 27 is what they considered older adults, kind of, not actually, we don't consider them older, but 65, right? So 27%. But when you look at those 27%, right? When you look at those 27% of people over the 65, they were people in the 80s, 70s. The data will actually show each of the ranges. I don't have that data on the top of my head in the paper. If you go in the paper, it'll show you number of people above 80, number of people above 70, number of, it shows you all that data. I don't have that on the top of my head. I should, but I don't. But when you're looking at those people above 65, those were 65-year-olds that were walking and talking and going grocery shopping and playing with their grandchildren and going to dinner. They're not the 85-year-olds who may be in a nursing home with multiple comorbidities. That is not the 85-year-old that was studied in this research. So when you look at incorporating these guidelines, not everybody above 65 can really handle these guidelines. These guidelines is not representative of every person in the sprint trial. Only 27% of the population in the sprint trial. And those two, they were healthy older adults. They were coming and exercising. They were playing with their grandchildren. They were going to church. So you've got to think about that when discussing medications with your physician. That's the first thing. Second thing, the sprint trial, as you can see here, did not include people with diabetes. So if you have diabetes, we follow the guidelines from the guidelines for hypertension based on the American Diabetes Association, which defines hypertension as a blood pressure greater than 140/90. If the individual is diabetic, the guidelines for defining hypertension is 140/90 and not 130/80, because they did not include patients with diabetes in the study.
Seems to me that diabetics would benefit more from this.
So the question is, why did they not include patients with diabetes in the study? That's a great question, right? Because they tried that in an earlier study called the Accord trial. This was called something called, not the Honda Accord, but it's called the Accord trial. And in the Accord trial, they looked at people who had diabetes and hypertension. And when they gave patients medications to control their diabetes, which is anti-glycemic index, along with medications to control their blood pressure, antihypertensive medications, they became really symptomatic. When you drop somebody's blood sugar and you drop their blood pressure, the likelihood for symptomatology and adverse effects is much greater. And so that is why in this study, they did not include people with diabetes. Great question, right? So that's the second point. If you're diabetic, don't follow these guidelines because we follow a different threshold. You know, another interesting point, and as a researcher, I'm a researcher, right? As a researcher, whenever you see a study that stops early, you got to think twice. Whenever you stop a study early, you stop it at its best point, or you stop it at its worst point. In this case, they stopped the study in 3 years at its best point. So we don't really know what would happen with the data if they continued the study for 5 years. We don't have the data because they stopped the trial early. So we need to think about that as we look at this data, right? We need to think about it a little more. What time do we have until?
You've got plenty of time.
Oh, I got plenty of time. Okay. Questions about it?
You for about 27%, is that a different 20% than?
Yes,
what was
yes.
there on the?
20?
Remember you said there was-
27% is different from the 25%. It just happens to be, yes, yeah, but it's a different rate. This is 27% reduction in all-cause mortality, but it's 27% of the sprint population was older adults.
And did they use a certain type of antihypertensives, or did they?
I think they used the big classes. I think I can't remember at the top. I'll have to go back to exactly see which antihypertensive, but it was multiple classes. But I think they left that up to the physicians.
And this predates the new surge of the SPGTs.
SGLT2,
Yeah.
and we'll talk about that when we get to heart failure. That's become a really important medication, the SGLT2 inhibitors for the management of heart failure. It's actually in the newest guideline that was published. One day we're going to do a talk on heart failure guidelines. The American Heart Association published a new guideline paper on managing heart failure in 2022. And so I'll talk about that in another session. But I want to go back to this slide, right? So let's say you or me go to the doctor's office, we get our blood pressure checked, and the doctor, and my blood pressure is 136 over 82. And they look at my risk for, cardiovascular disease, and it's, let's say, 20%. And the doctor comes to me and says, you know what? Your risk is 20%. Your blood pressure is 136 over 82. I think we should start you on a medication. You know what I'm going to turn around and tell that doctor? You're telling me I'm at 20% risk. I'm telling you I'm at 80% no risk. So we're just going to table this conversation because I don't want to take any medications. That's what I would tell the doctor. Yeah, you're telling me 20% risk. I'm telling you 80% no risk. See you later. Paul, would you do that? Would you say that to the doctor if they tell you to take some med? Yeah. Yeah. You trust them, but yeah.
But did your doctor actually give you a number when he said you needed to go on blood
Yeah,
pressure
he
medicine?
talked about that 10, whatever, because he said my age, based on my age and my.
Yeah.
I just had lab.
Yeah. So based on your risk and, but I think it's an important conversation to have. I think it's shared decision making. I think it's a really important conversation. What I'm trying to do in this research is share with you what is available so you can have a more informed discussion with the physician. It's just having a more informed discussion. So here are the guidelines. This is the sprint data. How can I be more meaningful in my conversation as to what I should really be taking? And is there an opportunity for lifestyle? Is there an opportunity for me to do other things? How often are you going to check my blood pressure to really make sure that I'm taking what I really need to be taking and I'm not taking too much? Because that's the big thing. So often we're giving people too much and it's causing more side effects and more problems. So I want to take this up to another level. So the bottom line we know from the SPRINT trial is that giving people medications can be really good in reducing cardiovascular events and in reducing cardiovascular related or all-cause mortality deaths. But now we have brand new evidence published from 2019 onwards on the benefits of antihypertensive medications in reducing cognitive decline in older adults. So now we know that managing people's blood pressure does not just help with their heart, but it reduces cognitive decline in people with older adults. And that is what we called the SPRINT Mind trial that was published in the Journal of the American Medical Association in 2019. It's called the SPRINT Mind trial. So what did they do in the SPRINT Mind trial? They took a subset of people from the SPRINT trial, 454 people from the SPRINT trial, and they actually looked at the MRI of their brain at baseline and after treatment. And they found less vascular injury in the brain. We can measure vascular injury by looking at something called white matter hyperintensity. That's a way to image the brain. And they look at vascular injury in the brain, injury to the blood vessels of the brain. And they found less vascular injury in people that were more aggressively treated with blood pressure medications. They found lower levels of cognitive impairment in people that were more aggressively treated with blood pressure medications. So now we have the evidence to show that managing people's blood pressure does not just help their heart, but it also helps with their cognitive decline, dementia, memory loss. So I want to end before, we won't have time for lifestyle changes today, but I want to kind of show you a short YouTube video that discusses the Sprint Mind trial and its implication for patients. Let's watch.
Is this set up so the thin guys will see it on it?
Is it set up?
There's a growing body of research on how blood pressure affects risk for cognitive decline and dementia. 2 studies published in the current issue of JAMA add important pieces to that puzzle.
Blood pressure control, especially in midlife, could be a very strong way for this country and the world to consider how do we tackle dementia, which is going to be one of the major conditions that affects society.
That's Shyam Prabhakaran. He wrote an editorial about the 2 studies.
Because it's so simple, because it's blood pressure control, it makes it even more of a reason to begin to do that even better than we do currently.
Let's look at the Sprint Mind MRI study first. Sprint Mind is the cognition substudy of Sprint. And in January, JAMA published the first part of Sprint Mind, which was a randomized trial comparing intensive versus standard BP control and probable dementia. In that study, researchers reported a non-significant reduction in probable dementia, but a significant reduction in mild cognitive impairment in the intensive treatment group over a 5-year follow-up. The new MRI study was also conducted by the Sprint Mind Research Group. In the new study, the researchers report on a subset of Sprint participants. The researchers looked at structural changes in the brain.
So not only are we talking about targets, now we're saying that there may be biomarkers in the brain that are showing protective or beneficial changes of blood pressure lowering.
The primary outcome in this study was white matter hyperintensity on MRI imaging.
White matter hyperintensities are an imaging feature of small vessel ischemic disease. This is a form of vascular injury in the brain.
If you're looking at an MRI, white matter hyperintensity or white matter lesions are best seen on a sequence called FLAIR. That's the one in the middle. White matter hyperintensity will show up as a bright spot, but what they mean clinically is a little less clear.
They are very commonly seen in small levels with aging, but they are an indication of the presence of vascular disease, and especially when the amount of white matter hyperintensity increases to a high level, those are really indicative of the presence of significant vascular damage, enough to cause vascular cognitive impairment or vascular dementia.
The findings of the study were twofold.
In Sprint Mind, intensive blood pressure lowering was able to slow down white matter hyperintensity progression, but did lead to some increase in brain shrinkage or atrophy.
The differences were small, but statistically significant.
So one has to grapple with whether, on the one hand, reducing a biomarker associated with dementia, white matter hyperintensity progression, is good, but is it okay for brain volume to be reduced? And is that shrinkage or atrophy going to counter the benefits of reducing white matter hyperintensity progression? We don't know the answer to that.
The brain volume can have multiple things going on. one thing that affects brain volume is neurodegenerative disease, for example, that tends to have a much more profound change over time than what we saw in our group. But even things like hydration status, for example, can change brain volume. So we don't actually know what that effect is due to. I think that's something that we want to try to investigate a little further.
Many other questions remain. What
So Shyam Prabhakaran, who is in this video, he writes an editorial and he kind of puts these studies all in perspective, and it's an outstanding editorial that really looks at all of the data into one little write-up that he has. So he's done a really good job. But the second part of the video talks about this other question, right? When you think about understanding blood pressure control and its effects on cognitive decline, when we look at the SPRINT study, it only looked at people who were in the SPRINT study for 3 years in their life. It's a snapshot of blood pressure control for 3 years in somebody's life. How do we understand the effects of blood pressure control over several years, all the way from people who are in middle adulthood to being older adults? And so they did another study where they looked at something called the ARIC cohort, the atherosclerosis risk and community cohort, where they started looking at people's blood pressure when they were middle-aged adults in their 50s, and they followed them to late life. And they had people come in, so this started many, many years ago, and they followed the same people when they were in their 50s to now they're in their 80s, and they had them come in 5 times into the doctor's office and take their blood pressure. And they categorized people in the study, these ARIC cohort, into different groups. Some people that remained with hypertension from midlife to late life. Some people that had hypertension in midlife, but then they had hypotension, low blood pressure in late life. Some people that were normotensive at midlife, but they became hypertensive in late life. So they categorized them into these membership groups. And based on your membership, they looked to see if people in each of these memberships had different levels of cognitive decline. Were there differences in cognitive decline in those people that were completely hypertensive from midlife to late life compared to people that were normotensive from midlife to late life? Were there differences in cognitive decline? And they found that those people that remained in hypertension were most likely to have the most cognitive decline. And they found that people that had hypertension in midlife, but hypotension in late life, so you give people who are hypertensive a lot of medication, now they become hypotensive, those people too had more cognitive decline. So something is going on where if we give people too much medication and you make them hypotensive, it increases cognitive decline. Let's watch the last part of the video.
white matter lesions are a risk factor for cognitive decline and dementia, but it's uncertain what structural or cognitive changes might be observed with a longer follow-up.
Everything about hypertension, people are hypertensive for, decades, half their life even, and they start having effects on their brain constantly, continually over that time period. And we were measuring kind of a very short window in that period.
And it's this long-term effect of blood pressure on dementia that's addressed by the ARIC study, published in the same issue of JAMA.
So this is the cohort called the Atherosclerosis Risk and Communities cohort, abbreviated as the ARIC cohort, and it was started back in 1987. So people were enrolled in this study during middle adulthood. Having this midlife data is really what makes a lot of the work we do in this cohort unique, because we can look at how midlife and late life factors interact to influence late life outcomes like dementia.
After enrollment, participants' blood pressure was measured during 5 in-person visits over 24 years. Based on these measurements, the researchers categorized the participants into 5 blood pressure patterns.
What we did was we saw how like, category membership or these longitudinal blood pressure patterns related to subsequent risk of dementia. So developing dementia in late life after blood pressure had been measured.
The findings suggest that blood pressure, even as early as midlife, may influence longer-term cognitive outcomes. 2 patterns were statistically significantly associated with incidence of dementia: chronic hypertension and midlife hypertension followed by late-life hypotension.
We did compare the 2 groups because we were really interested in this question, like is the midlife hypertension, late life hypotension group actually worse than having, chronic hypertension? And when we compared the 2 groups head to head, we didn't see any statistically significant differences, and that's important. But there is some separation between the groups that may or may not be, just a normal variation.
It may be that this is all just exposure to a longer period of hypertension from midlife onward, but there was a potential signal of increased risk with hypotension later in life. So they could be interacting with each other in some complex way where it sets the stage where very low blood pressures is particularly harmful in late life.
I would encourage further research looking at this group as, potentially being more pathogenic than the group that maintains elevated blood pressure, because I think it's important for understanding how to treat blood pressure in older adults, especially older adults who have a chronic history of hypertension in midlife.
And this is key. Together, these studies suggest that hypertension is a modifiable risk factor for dementia, and more intensive blood pressure control from midlife might reduce dementia incidence in hypertensive patients.
So you can find this YouTube video. If you just go into YouTube and you put hypertension and dementia, you will find this one that was published by the American Medical Association. All right. So I think I'll end there. The take-home points today were really that hypertension is a modifiable risk factor. I wanted to share with you the new guidelines and how those guidelines came into evolution through the incorporation of the SPRINT trial. I think I'm hoping to empower you not only with the new guidelines, but the importance of shared clinical decision-making in talking to your physician about the most appropriate dose of antihypertensive medication based on your goals and what you want to see achieve to improve your quality of life. It's not about just always taking 2 medications or always taking 1. And if you're incorporating lifestyle into your regimen, how often is that blood pressure getting checked so you can make necessary adjustments? And then finally, this new body of evidence that is giving us really good data on blood pressure control, not only for the cardiovascular system, but more importantly, for our cognitive sustainability and reduction in cognitive decline and dementia. And I think we'll end there and we'll pick it up the next time on lifestyle changes and hypotension and other factors related to blood pressure. See you guys later. Thank you.